ctDNA. That was a topic actually we thought we would cover the last time Dr. Cardo spoke about multidisciplinary tumor boards. And that was a discussion in its own and took the hour. So I asked him to continue. The slides were sent to you at that time, but if you want the slides again, I may ask Adele to send them to you, Jenny, and you can distribute to everybody. Okay.
Thank you so much.
Yeah. And Adele, thank you. Thank you for being here. So Adele Kardosh is actually the chair of our multidisciplinary tumor board that runs every week. We discuss all our new cancer cases, GI cancer cases, and recommend and get a consensus on the recommendations on the treatment. He's a champion of precision oncology and an immunologic microenvironment of GI cancers, particularly colorectal cancer, and has been really a trusted colleague and an exceptional physician. So I'm looking forward to learn from him about ctDNA. That it's actually, I don't know, Adele, if you had a time to read the New England Journal of Medicine article that just came out about liquid biopsy of cancers for colorectal cancer. This is it has a lot of traction and even made it to the New York Times. So anyway, with that, I'm looking forward to your talk, Adele, and welcome to all.
Thanks, Liana. I'm gonna turn red with all these positive. Thank you. I don't know what to say. I had less than 2 hours to prepare to let you know. So some of the slides are actually taken from the recent GI Cancer Symposium in San Francisco that was presented. I usually make it a little bit neater, but I did not have a lot of time. So I'm happy to talk about it. Please stop me halfway to ask questions. I'm trying to go through the slides and happy to answer any question that come up. So there've been a lot of talk about the value of ctDNA, and there is a lot of push into making it into the clinical as a standard of care treatments to a lot of our patients, and that yet not happened. And so where do we stand and what is the data that supports this? So let me see. Here we go. So as an outline, we'll talk a little bit about the different kind of ctDNA that we're actually being used right now. The focus is about stage 2, 3, and 4. I'll mention one thing about rectal cancer based on the dynamic study from Australia, and then I'll present general thoughts. So not to introduce, I'm sure all of you know this, circulating free DNA and circulating DNA, just definitions. So circulating free DNA is a small fragment of DNA that circulate in our body. This tends to be normal tissue. This is coming from mainly hematopoiesis, but
ตื่นแต่เช้ามานั่งฟังประชุม
Sorry, please mute all the microphone. Sorry, Prof, please go ahead.
Really short. It's less than 2 hours. So when we look at these patients, it's truly a glimpse. It's basically a snapshot in time of when the blood was drawn. And it's truly looking into like a needle in a haystack, because you're looking for a very small thing in a huge amount of normal circulating cell-free DNA. And so we knew about this from a long time, but the technology was not strong enough to highlight that. But now we have better and better technologies. Now, it's important to kind of consider what kind of tissue we're looking at and what kind of testing we're looking for, because there's a whole array of different testing, different specimen that we can do the test with, including how do we store this test? How do we store the blood? The timing of analysis. All that actually affect the tissue, mainly affect the small sequences of DNA that we actually had. So we think about circulating DNA as to an important part because it has a lot of advantages as compared to what we've been dealing with regard to tumor tissue, but yet it does have disadvantages as well. Just to differentiate between the two, tumor tissue mainly require biopsy. There's a lot of side effects. It's high risk. Tumors tend to be heterogeneous. So if we're getting a biopsy, we don't know if this metastatic site versus the other metastatic site have the same mutations, or even the same metastatic site or the same tumor have different heterogeneity within itself. There is no assessment of the tumor load that we have. We're looking at just the one biopsy. And then it's kind of, the existing tissue is easy to actually process and adjust. On the other hand, ctDNA is less invasive. It's easy to test. You can actually get better representations of the metastatic heterogeneity because you're not looking for one tumor, you're looking for all shed from all diseases, especially if somebody has metastatic disease. It is a quantitative analysis, so you actually can tell the amount of ctDNA you had, but it requires specific processing. And we know now that the tumor heterogeneity is a big deal because from a lot of studies that already been established in GI and non-GI, when we biopsy tumors, if we biopsy different metastatic sites, for example, we get actually a different mutational pattern. So ctDNA is a way for all mutations at the same time, in a sense, theoretically, for all the disease that is actually present in a patient's body. The problem is that detection is different. Well, detection from different cancer is different because different cancer tend to shed ctDNA differently in a different amount. But in the same time, detection into each metastatic site tend to be also different. So there's a lot of challenges of deciding how important and how efficacious ctDNA might be. Interestingly enough, we're learning more, and as you see from some of the data that we have, is that colorectal cancer tend to be the highest shedding, one of the highest shedding tumors. However, in metastatic sites in the lungs and the peritoneums, they tend to be very low shedding tumors. So one has to make sure that we're not missing any information by getting these levels and not missing truly metastatic sites. All right. And
Adele, are you still sharing your slides? Can everybody see your slides?
do you guys see my slides?
No,
Yeah, all of a
no.
Give me
sudden
one
we
second.
lost your slides. Yes.
Okay. Let me share again.
Thank you.
Thank you for letting me know. Do you guys see this?
Yes, yes.
Okay,
Yes.
perfect. So I don't see the chat. If anybody put questions, please let me know because I can't see that. Okay, so what methods do we use to look at different mutations? Well, it depends what we're looking for, truly. If we're looking for a specific point mutation, we can do simple PCR to detect that, something like if you're looking just for a BRAF mutation. If you're looking for a panel, like next generation sequencing, there's two kinds. You can do a gene panel specifically, and that is less comprehensive. It is very high sensitivity and low cost, so you can sequence a lot. But you can also create like a hybrid capture sequencing, and that gives you a high DNA input and more complex workflow. But if we can actually do a more deep dive and get a comprehensive next generation sequencing, looking at a whole exome, that takes a lot more time. It's very low sensitivity and very expensive. And so the DNA approach for that, I don't know why. Are you guys seeing this little window in the middle? Okay. There we go. All right. And so that's for the ctDNA approach, there have been two kinds. There is the tumor-informed and tumor-naive. Most of us are more aware of the tumor-informed, and that's basically when we have tissue. The tissue tends to be analyzed through whole exome sequencing, specific mutations identified, and these mutations tracked, and that's what we called minimal residual disease. It's very good for response monitoring and surveillance. On the other hand, we can think about tumor naive, and that's where a pre-specified mutation sequencing have been built as a primer library, and these then get analyzed whole to detect if one of these specific mutation is present. This has low sensitivity as compared to MRD, and it does not, it's not very sensitive to use for response or surveillance. It can be more helpful to detect mutational resistance, although the technology is slowly changing, as I will describe. So tumor-naive ctDNA, using current guidelines, the biggest use for kind of non-informed tend to be if you're looking for a specific mutation, for example, lung cancer. And for that, there's a lot of liquid biopsy. There's the Foundation liquid biopsy, the Guardant 360. Now there's the Guardant Infinity. The focus, and there's a lot of academic centers that have their own assay as well. MRD, on the other hand, is basically a selection of specific clonal mutations, as we talked about, creating specific primers for that specific cancer, and then trying to detect these primers. In this situation, we're detecting the specific cancer. So if a patient developed a different cancer, at that point, ctDNA will not be able to detect the secondary malignancy. It's really specific for that one malignancy that been sequenced and a specific mutations have been identified, or specific sequences have been identified. This is some of the assays that are available right now. Most notably, everybody knows of Signatera, but there's other assays. Haystack is gaining a lot of interest because they do something a little bit different, and I'll explain about on the panel size. But the differences between them mainly tend to be, one, first, is it tumor informed or not? And the only one I mentioned here is the Guardant, which sits all the way to the right, and that is tumor agnostic or tumor naive. On the other hand, the other ones, you can see if you go all the way down to the panel size, Signatera uses 16 to 19 variants to decide on their whole exome sequencing the tracking of that specific cancer, whereas all the newer technology are using now about less than 50 variants. So there is a lot more than what Signatera provides. However, Signatera, at least in the US, have the biggest traction and the biggest market for now. So what is the data that we have in colorectal cancer and MRD? Well, this goes back, way back from like 2016, when a lot of the data have showed that basically right after surgery, if patients are evaluated and a ctDNA is found, then that is already considered a prognostic factor differentiating patients who are ctDNA positive versus ctDNA negative and showing significant outcome differences, whether it's stage 2 or whether it is stage 3, and I'll show you the data for stage 3 after. So one of the biggest the biggest articles that came out was actually this study looking at a dynamic study from stage 2, where they looked at about 455 patient stratified stage 2 for CT-guided management versus standard management. These patients were the standard management, basically patient decisions based on what the treatment is, whereas the ctDNA guided, if the patient were positive, they were treated with chemotherapy. However, if they were negative, they were not. And they wanted to see whether there was differences between utilizing ctDNA and saving some patients some chemotherapy. Overall, the groups were very similar. There were some high-risk features, especially T4 features in this group. But interesting enough, if you look at the data, there were a lot more patients that had higher risk patients in the ctDNA guided group. Also, the treatment were a bit different, where and I'll highlight that at the end, where patients were either got oxaliplatin doublet or got a single agent 5-FU. And since we're here, you can see that a lot of the standard management, which is not typical for the US, a lot of patients got single agent 5-FU as compared to the doublet in the ctDNA guided. That said, when the data was looked, there was no difference in recurrence-free survival in the two groups, whether that ctDNA management or standard management. And when we looked at ctDNA positive or negative, patients who were negative, who did not receive chemotherapy, continued to do even better than the patients that were ctDNA positive, following that outcome that we can actually save patients a lot of chemotherapy and toxicity. Also, when they looked at high-risk features and low-risk features, you can see here that this continues to be the case. So even in ctDNA negative low risk versus ctDNA negative high risk, the high risk patients do worse, whereas ctDNA positive disease is similar to high risk features. So there's a lot that we still don't understand from how best to use that ctDNA, whether if they're ctDNA negative but high risk, whether one single analysis of ctDNA is sufficient. That is changing the field right now, because as the data have matured, we're doing dynamic follow-up for these patients and detecting patients who will have recurrence much earlier points. So high risk have a higher risk of recurrence rather than low risk, as we know from before. So in summary for that, at least, we ctDNA guided strategies in stage 2 colon cancer did not compromise recurrence-free survival. However, the ctDNA negative high-risk patients had similar outcome at ctDNA positive, even though they were still negative. And 5-FU alone, really, at least in the US, is not a standard for those patients. ctDNA negative had low recurrence risk without adjuvant chemotherapy. Again, low risk stage 2 typically don't receive chemotherapy here. So a lot of questions about still how really to use this amazing technology. To build on that, actually in this year, there was the much awaited COBRA data looking at stage 2 and 3. It was a phase 2 looking at stage 2 colon cancer. So this study wanted to do the similar thing. Stage 2A, low risk disease, basically randomizing to standard of surveillance, since we don't treat these patients, versus arm 2, looking at assay directed. And in those, if the patient were ctDNA negative, then they go to surveillance, and if they were positive, they get chemotherapy. Well, the data that the assay they chose to use in this was the ctDNA non-informed assay, different from Signatera. So this is not an MRD. This is the Guardant lunar assay. It's kind of a different version of the Infinity assay. And they started the assay, but by the time the assay developed, there was a lot of changes into the company's interest in that assay. And unfortunately, when this essay started, COVID just hit, and the accrual in the study was not that great, and eventually the study had to close. So when they reported the data, they reported in a very small arm of patients. They still see that ctDNA clearance with surveillance versus chemotherapy. So there's a benefit to chemotherapy, but the numbers of patients are very small. So that was a bit disappointing. They did indicate that certain patients with stage 2A might be positive that are missed, but overall the data is so small for us, we cannot infer too much of it. In the same meeting, actually, Dr. Tay actually presented the rectal dynamics. So I showed you the New England Journal of Medicine colon dynamic study. This was the rectal dynamic study. And again, unfortunately, due to COVID, this study was not able to accrue as they needed and had to close early as well. So this is for locally advanced disease, again, randomized 2-to-1 for ctDNA informed management versus standard care, similar to the New England Journal of Medicine, the colon dynamic study. And again, similar, you can see that a lot of patients receiving single agent 5-FU versus the doublet. They had high risk disease as well involved in this group. And what they show is that, again, patient with ctDNA positivity had worse recurrence-free survival than ctDNA positivity. However, what was interesting, again, to highlight, as I mentioned, is what they noticed that the recurrences for some patients we tend to be lung and peritoneal with very low detection levels. So these patients who had lung and peritoneal recurrence, these assays are not great to detect, whereas the liver and liver only are actually really sensitive to such an assay. So overall, even though the study was not fully accrued, there was still statistical significance looking for locally advanced patients with neoadjuvant chemoradiation followed by surgery, with differences between 46 and 77%. And there was an RFS benefit for post-op ctDNA negative patients. But the study did not accrue completely. We actually have an observational study here at OHSU utilizing similar assay, but using the Signatera data. It's a smaller study than this, and we're currently accruing for it. So stage 3 is the same as stage 2. We can see that recurrence-free survival is much better in patients with ctDNA positivity. What is interesting, actually, from data I will show you is that there's highest rates of recurrence and ctDNA positivity in stage 3 as compared to stage 2. Looking at DFS, this is the IDEA trial looking at 3 versus 6 months. And when you look at patients who, in the IDEA trial, who were ctDNA positive in red and received only 3 months of chemotherapy, they had the worst outcome. Whereas given patient chemotherapy, if they were ctDNA positive for 6 months, more aggressive regimen, seemed to do much better. The best group are the patients always who had ctDNA negative. That is, okay, that's the same. And so what about doing dynamic studies? So far, most of what we looked at is basically getting a single ctDNA right after surgical resection. Can we use this ctDNA to do more? Can we do multiple evaluations? And what you see from this is the data shows that we can actually detect it in better sensitivity, plus the issues that went to detect these patients. So if we look at all the way to the left, you can see that if we get more than just one ctDNA, there is we can detect in 40 times more likely to detect the relapse. So if we do dynamic ctDNA follow-up, we have a better chance of detecting relapse early on. If we do it just twice, right after chemotherapy and after surgery, there's 17 more likelihood to detect relapse versus if we do it just one time. So this is the Galaxy study in Japan. Interesting study. It's an observational study where all patients with stage 1 and 4 get ctDNA, and they do dynamic follow-up with these patients. And similar to all patients, if right after surgery in colorectal disease, patients have negative ctDNA, they have a better outcome as compared to positive ctDNA. And whereas similar cases in stage 2, stage 3, and stage 4, but what you see suddenly is that as you progress through stages, patients do worse, even for patients who give chemotherapy. So this is green is with chemotherapy, and these are all basically ctDNA positive patients. So giving chemotherapy, you can actually prolong DFS with these patients and improve overall survival possibly. The only difference in Japan is that not all patients get chemotherapy, as you can see in other data, and that was the hard part about this. But overall, patients who are negative with chemotherapy, without chemotherapy, it was all the same. So ctDNA could be a good assay to track patients as they go through treatment. And if patient convert, so if somebody starts with we know that green, negative to negative, they do the best. But if a patient start with ctDNA positive and converted to negative, their outcome continue to be very good. Whereas if patient starts with a negative test and becomes positive, their outcomes tend to be worse, and the worst patients who don't respond to adjuvant chemo and continue to progress. So one of the biggest studies in the US, that's the Bespoke study. It's a kind of an observational study looking at basic continuous monitoring with ctDNA in patients with stage 1 to 3 colon cancer. And they presented in GI ASCO this year an interim analysis of their studies. And so they have the studies for 2,000 patients, and they basically were at 1,700. They analyzed 700 patients almost, and they looked at the surveillance cohort and the MRD cohort. And what they see in stage 2 and 3, similar to every other data point I've shown you today, is that if somebody is negative, they tend to do better than patients who are positive. But they also saw, again, the benefit of chemotherapy for the patients who are MRD positive, but not the MRD negative patients. So if you look on the left side, these are patients MRD positive. They get chemotherapy, and you can improve these patients' disease-free survival as compared to patients who continue to be who go on observation. Whereas in DNA negative, there were no difference whether the patient got chemotherapy or not. So again, in certain patients, we can actually save them a lot of toxicity. I thought this was one of the most interesting slides they actually presented. What's interesting about this is that they showed that ctDNA clearance enhance disease-free survival, but what they show is that about 80%, 85% of the patients who transiently clear, this is the green graph here, develop molecular recurrence by 15 months. So that's already interesting because patients who get ctDNA ask all the time, it's like, okay, so what is my numbers? What is my outcome? When should we repeat scans? Should we get chemotherapy? So what we're seeing, at least from this data, is that 15 months is an important number, and that helpful to actually kind of convey in patient, because again, there is no urgency to do something now immediately. The other problem that, well, the other question that everybody was asking in the field is like, when should we get the ctDNA? If we wait too long, would we miss a window for the ctDNA to be informative? Or if we get it too early, would it be the cell-free DNA, would it affect the response? What if we get it during chemotherapy? And that this study was presented back in a year ago in GI ASCO by Stacy Cohen, and she looked at data from Signatera, looking at almost 33,000 patients and analyzing almost 15,000 patients. And what they see is that the ability to detect ctDNA persists. There is increased background noise, but you can actually detect it. And most people tend to actually get ctDNA 4 weeks after surgery. And you're able to detect it without, this side, you can able to detect it without too much interference. So when patient get it at baseline, within 2 weeks after surgery, you can see that there is increased background to it. This is their annotated 400 cohort, but there is background to it, but you're still able to detect it. But then that seemed to stabilize, and so even patient getting chemotherapy, you're able to detect the ctDNA. Further justification that utilizing ctDNA dynamics, getting multiple testing of ctDNA is still feasible and could be interpreted. And this is the numbers, again, specifically looking at the previous slide, where you can see there's a lot more right after surgery, cell-free DNA. And as we go further out, there is less ability to detect. So the other issue you can see here is that ctDNA positive is associated sometimes with shorter recurrence-free survival with patients. This is in oligometastatic disease. You see that even in oligometastatic disease, patient, when you detect ctDNA, there is benefit to that treatment, because patient actually could be negative or positive disease. And in many, and I apologize if you guys are hearing my dog screaming. This is important because a lot of time we talk about synchronous disease, and in synchronous disease, liver resections may be helpful by ctDNA, and that's something that comes up in the tumor board on a regular basis for us. Should we resect? What should we do after resecting on oligometastatic disease? Should we give more chemo or not? And maybe ctDNA would be a good thing to utilize to explain all that. There was a study, because one of the big questions that actually comes up all the time about what is the utility of ctDNA? Should imaging be done either way? Should we do ctDNA for recurrence? And there was this interesting study that looked at the utility of ctDNA imaging and CEA. And what they found is that in about 48 patients who underwent curative resection, they looked at 31 stage 1 and 17, and they had patient recurrence in 6 and 9 in stage 4. And what they see is that ctDNA positivity was, again, a poor detector in patients who had lung and CNS disease. So patients still had metastatic disease, but ctDNA was not able to detect it. And they actually had 2 patients that developed liver metastases, but it was a bit of indolent disease, and they could not, the patient required just resections. And in other two patients who developed recurrence, they could not detect it on imaging for over a year and a half. So the patient's ctDNA was positive, but yet there was nothing on imaging. And should we have acted upon this and give the patient chemotherapy based on a ctDNA? And the answer for these two patients, probably not, because unclear at that point if we have benefit these patients or not. So these are questions that are still not answered in the field, as like, should we act on ctDNA or should we not act on ctDNA? It's really not clear. So as a summary, I think ctDNA is a good prognostication marker for recurrent colorectal disease. Dynamic studies are actually more predictive, so getting multiple ctDNA is better. Higher concentration of cell-free DNA does not impact the ctDNA, so it doesn't matter when we get it, we're able to detect it. Testing for MRD between weeks 2 and 8 is similarly sensitive, so we don't have to wait for that first visit when we see the patients in the clinic. However, the role of adjuvant chemotherapy is still unclear. There's conflicting result about these retrospective analyses. We don't, the studies that we waited for real comparison, unfortunately, because of COVID, have not materialized. So now we're still waiting for other studies to report. And we don't know truly what the benefit of chemotherapy is. Other challenges for MRD is the false negatives and versus false positive result. Really, insufficient sampling, low shedding tumors, low sensitivity, sequencing error, depending what assay we use. It's hard. I have many patients that get ctDNA that suddenly become positive, and then with repeat ctDNA, they're negative, or vice versa. Not all studies have shown benefit to ctDNA. There's some studies that show that, even though you see the DFS, we don't see the OS benefit. So far, we don't have a real OS data. We talked about low sensitivity, low volume disease, that we cannot maybe detect the ctDNA. And whether this is a truly predictive for adjuvant therapy, again, we truly don't know. And when to treat patients, very unclear. So in conclusion, I think ctDNA has significant potential. This is why, at least for in the US, colorectal seems to be leading in this field. ctDNA is useful molecular and genomic analysis. Helps if patients have difficult biopsy. So considering even non-informed, we tend to use that sometimes. MRD testing post-resection has a good potential for prognostication. And ctDNA positivity is associated with high risk of recurrence. So if somebody's positive, most likely they will develop cancer. The problem is, would they benefit from chemotherapy? We'll wait for the trials. And ctDNA negative is unclear. Again, if somebody's negative, that doesn't mean they don't have cancer. Unclear if we're actually detecting the cancer. So questions: is there benefit to change in treatment based on ctDNA? ctDNA versus CA versus imaging, should we combine all of it? Again, utilizing ctDNA tracker mutations, and costs. That's a big deal, actually, for many of us now, as insurance companies start delving into, and a lot of these companies charging us a lot of money. Thank you. That's a lot of information.
Thank you very much, Prof. It's quite clear, easy to comprehend. Anyone have a question for Prof. Kadosh? Dr. Vinita, any question from you?
It's very promising information, but it's quite complicated as for GI doctor like me. But as far as I understand, there's some very small window for using ctDNA for stage 2 colorectal cancer without high risk features. Is that correct?
Yeah, I think the biggest data for stage 2 that we have is basically for patients post-resection. If they're negative, the data seem to indicate that they have better outcomes versus positive patients. Most of the dynamic data supports really more in stage 3, but I think the most data we have is getting in stage 2 is getting the ctDNA right after surgery.
What about your current practice right now for using ctDNA in colorectal cancer patients in FSU?
Yeah, good question. We actually trying to get it on most patients for academic reasons. But I personally think that the biggest value as it is today is for patient with stage 2B and patient with stage 3B. As you all know, stage 2C is very high risk, and these patients probably require full chemotherapy. Stage 2A, very little benefit to adjuvant therapy, whereas stage 2B is a question mark. And I think that's where ctDNA might be actually the most beneficial, is for those patients that fall in the middle.
Thank you. Ajahn Lakshmi, any question from you for him? Pathanoso.
I'm sorry, I'm just still in the meeting, so
Okay.
I
Okay.
have to catch up. Yeah, thank you.
Okay. Sorry, Kun Meta, any question from you?
No any question ค่ะ thank you ค่ะ doctor
Okay. How about Korat, huh?
No any question. Thank you.
อาจารย์ต้นคะอาจารย์ต้นพญาไท2 Okay. Dr. Art, huh?
Yeah, thank you, Professor Cardos, for such a comprehensive talk and then many new information data on ctDNA. However, I think eventually when we come to clinical practice and when we come to deal with importantly the insurance company, they would need a very rigid evidences or guideline even, or FDA recommendation even to use something new like ctDNA. Yeah, we have been followed the data on ctDNA for many years, and I think even today there's no promising piece of data to support us as one of the new hope for like as a biomarker for any kind of prediction or any changes in treatments. So in your opinion, which indication would be the future strongest, I would say, indication, if you have to repeat some of what you have talked about, what would be the bright future for ctDNA application clinically?
Oh, I agree with you 100%. I think that's the reason why it hasn't been adapted, and it's a challenge, and the inconsistency of it for depending on like where disease site will be. I think if ctDNA might be utilized, I think it has to show the dynamic of it, which again will be hard from a financial perspective because it will be expensive. But following patients on multiple blood draws might be actually the best way to track the patients. And back to the point I had, I truly think maybe stage 2B might be the easiest way for us to justify the use of it, because for stage 2A, less than 5% benefit of chemo and very rare recurrence of cancer For stage, 3C and above, these patients require chemotherapy. And so, if we think about maybe stage 3A, patients who are going to get short, 3 months Kpox, and they have ctDNA positivity, at least from, retrospective analysis of the IDEA trial, 6 months might be more beneficial than 3 months. Then we justify a 6 months treatment versus a 3 months Kpox. And unfortunately, it's all retrospective, and there's no yet good data, solid data to kind of push the field forward. And a lot of the phase 2, 3 trials that we're going to conduct have kind of failed to accrue and withered away.
Can I ask you a question, Adele? I mean, from everything you told us, truly there is no role for tumor agnostic ctDNA. However, I mean, I thought the study at New England Journal of Medicine was agnostic to tumor as predictive marker. So I don't know if you have any thoughts about that, because what most of the studies are based are on tumor-informed ctDNA. So I was wondering about your thoughts on that, because I find it intriguing that it's getting that kind of momentum, traction. The ctDNA, the tumor agnostic ctDNA.
Yeah, that's a good point. I think Guardant is pushing very hard, and they're developing more and more sensitive assay for tumor agnostic. One of the reasons actually the COBRA study did not, other than COVID, did not accrue is that because Guardant have developed a new assay that was more sensitive than the study that was initially started with and utilized. So from that perspective, I think there is a role, unclear yet, for how to assess surveillance or prognostication for tumor agnostic, because it's built on a specific mutations that we actually know, rather than a mutation that are specific to that disease. So yeah, it's a big problem. I sit on the NIH task force for rectal, and actually there's a lot of that discussions about tumor agnostic, because it's hard sometimes for rectal cancer to get these, enough tissue to do tumor informed, but yet it's not specific for the tumor agnostic is not good enough to track patients. And so, it's hard. I think the excitement is leading the science rather than the science leading the excitement in this field.
We will grab on anything we can get sometimes to give people hope. It's just human nature, I find. So I want to thank you. This was outstanding. Please share your slides with you can send them to me, and I will just send them to Dr. Wanapat and to the Thai colleagues. I cannot thank you enough for your time and your great talk.
Oh, thank you. It's always fun to come and talk to you guys. So anytime.
Thank you very much. And your
I
lecture.
have one more question, please.
Please.
Yes.
I'm Dr. Puchai, medical oncologist from Smith Hospital. Do you think we should offer ctDNA testing in stage 2A disease with multiple high risk features or not, such as poorly differentiated or high tumor burden or lymphovascular invasion, based on data right now?
Yeah, very good question. I think, I think for high-risk disease, these patients most likely need chemotherapy, right? Because if you have a T4 disease, for example, stage 2 T4 disease.
If T3 disease.
I think T3, yeah. So I'll tell you why. So I think T4 disease don't need it, but T3 disease actually might be the only this is what I'm saying, 2B disease is these high-risk patients might be the ones that actually benefit mostly from a ctDNA. If there's access, I think yes, because we struggle of how best to do this, and we say a discussion with the patient, but I think for those patients, ctDNA would definitely be informed, because I would usually offer chemotherapy for those patients, and the data, for the most part, is not very clear. I mean, based on the stage 2 from the dynamic study, these patients do as good as the standard treatment, right? But in general, if somebody was ctDNA positive, I think they should get chemotherapy.
Okay, thank you so much.
Just one last quick question. When you say that it's prognostic indicator, how often are we supposed to do checking ctDNA? Once a year or what?
So at least for now, based on the trial, the ctDNA is done once every 3 months. Based on, for example, the bespoke trial, it's once every 3 months. And the way, at least in the US, it's approved. So as the patient get approval for ctDNA for 4 testings, which is basically a year long. So at least Natera is doing, when patient get approved for it, they get 4 tests. That's kind of like the goal. It's not 1 test, it's 4.
Thank you, Prof. That's all. Thank you.
Yeah. Can I have one quick question, please? I'm not sure if there is any upcoming future liquid biopsy rather than ctDNA.
So I think the only liquid biopsies, so Guardant has a liquid biopsy tumor uninformed assay that they're really pushing. It's the newer Infinity or Galaxy study. They keep changing it, where they're utilizing specific sequencing, and they're using DNA methylation to detect whether a cancer is present or not. They're still behind more or less as compared to MRD. But that's the best assay that is on the market right now. But we still don't have a lot of data from it.
Thank you. Thank you so much.
Just want to put the plug on Missy Wong's phenomenal research. She's studying circulating hybrid cells, hybrid tumor cells with normal cells. That is not a DNA, it's number of hybrid cells, the fusion cells that she's studying. I know it's not in the market, it's nothing like what presented today, but there is a lot of research in different forms of liquid biopsies to see to predict recurrence, but also to see the state of the cancer in even when it's not seen radiologically or by CEA. So I know Missy is going to be publishing this work that she has published some of it, but it will be publishing more on this work. So
thank you, Prof, for sharing this as well. I think we can say goodbye to one another now, since no more question. Thank you very much, and we hope we can also upload the slide and the lecture onto our knowledge management system for learning credit for other people as well. Thank you.
Thank you.
thank you.
Bye-bye.
Thank you.
Thank you. Thank you.